and welcome to this SOGO meeting. As you know, we have completed all the webinars on the various aspects of urologic oncology, including each subject, prostate, bladder, everything. It was decided at the SOGO meeting that let's go something beyond. And Dr. Ginil was interested with doing this webinar on artificial intelligence, which we have been hearing for last decade or so, more often from last 2 years or so. Various things have been talked about artificial intelligence. If my memory goes back, in 90s, we used to have something called artificial neural network, which used to come and read in as far as the CA prostate is concerned. Of course, the progress was going on, and I was told that by 2016, there is a lot of budget allocation for artificial intelligence development. But it's a completely new charter for us, and we are going to go along this in future. The only concern which I explained to Ginil was that currently we are into a master and slave technology. That is, we are masters and the robot is a slave, but especially in uro-oncology. But it should not so happen that we become slave and the artificial intelligence becomes master. But of course, jokes apart, I think this is a very interesting topic. And as I note that there is a large faculty, both national and international, and we are going to have a next 150 minutes of a feast of artificial intelligence to you. Thank you very much and welcome to you all. Dr. Ginil, please.
Ginil.
Thank you, sir.
Yeah.
Thanks to Jagdish, sir, for the welcome. Actually, if you don't become you don't want to become the sage, you have to master the art first. So I feel that this meeting is very important, and I personally welcome and thank all my faculty members for being with us on this weekend, sacrificing the family time to educate us on this interesting topic. We are going to hear from them how artificial intelligence and machine learning is going to change the future of uro-oncology. Earlier in our younger days, we used to dig out data from old files stored in file racks. Now the data is, whether it is radiology, pathology, or clinical science, is stored in digital format. The expense of data storage has reduced and the volume of data increased. It became more organized naturally when it is stored in the computer and become more standardized and easily retrievable. When the quality of data improved, naturally the different studies had better outcome result. The data scientists started trying to make algorithms to reproduce the same data results in different data sets to find solution for clinical problems more accurately. And if you are feeding to computers, you can to some extent automatize that. So, but there are some issues regarding the data. Often we neglect these issues. Different variables may have different weightage, like in a prostate cancer, like a PSA grade and palpable tumor may not have same weightage in the outcome. So there can be interaction between these factors. So human brain cannot calculate all these factors, especially when multiple variables are there and volume of data is high. That is why artificial intelligence and machine learning is very important to us and is going to help us. When a data scientist and an expert of the subject sit together, it can lead to wonders. That is what is happening now. And I wish this meeting may be a humble initiative in that direction for all of us. We have experts in different fields to discuss about the impact of artificial intelligence in different topics related to uro-oncology. So, we have a legend in this field, Dr. Bandari sir, to share his vision and to make the final comment. I invite Dr. N.P. Gupta and Dr. Anup to start the first session and introduce the speakers.
Thank you, Dr. Ginil, for inviting to join for this very exciting topic and a hot topic, I will say, because the future lies in artificial intelligence. As you know, now the machines or the computer is taking over the human intelligence. And this work is going on not only in medical area, but in many other sphere of life. In medicine, as it has been mentioned already, from 1990, the work is going on. And I know personally that Dr. Bhandari, who doesn't need much introduction, and he is much ahead of the time, and his thinking is like that. And I personally know that last 10 years, he is very actively involved in the field of the artificial intelligence, and he has interacted with us personally several number of times about his projects. So we are lucky to have Professor Bhandari, who is currently the Director of Robotic Surgery Research and Education at the Vetikuti Urology Institute at the Henry Ford Hospital in Detroit. And he is going to speak his perspective about the role of artificial intelligence in uro-oncology. Dr. Bhandari, please. Dr. Bhandari is with us. Ginesh?
I think
I'll reconfirm.
yes, he has not joined the faculty.
I'll reconfirm. Can we go to the second talk? Meanwhile, I'll contact.
Anup, can you invite please the next speaker?
Okay, thank you very much, organizers of SOGO, for inviting us for this very exciting session. And I'm going to invite the next speaker, Mr. Saurabh Dani. He is currently pursuing the PhD in machine learning algorithms and cloud computing in Swinburne University of Technology, Melbourne, Australia. And his specialties are to detect anomalies, develop advanced ML algorithms, and powerful AI systems. So over to Mr. Saurabh Dani for your interesting talk. So Mr. Saurabh, you can now share your screen. Can you hear us?
Yeah, I can hear you. Am I audible?
Yeah, you're audible. Please share your screen. Yeah.
Sure. So I hope my screen is visible for everyone.
Yeah. Please make it full screen and then you can continue.
Sure. So, hi everyone. I'm Saurabh Dani, and I'm a PhD student in Swinburne University of Technology, Australia. I'm doing in specialization in machine learning and anomaly detection and cloud computing. So today I would like to talk about how these technologies such as deep learning, AI, and NN in uro-oncology can be implemented. So to give you a content about what I'm going to discuss today, it's about the introduction about AI, deep learning, and ANN. What's the difference between these technologies? Even though they do perform the similar objectives, so what's the difference? After that, where do we apply these technologies? Where are the application scenarios, and where are the current trends and benchmarks, and how are the challenges associated with the implementation? Also, how, if at all we are doing all this stuff, then what are the future possibilities? We do that, we'll conclude with the questions. So, okay. To give you a definition about AI, deep learning, and artificial intelligence, as artificial intelligence name itself says that it's the intelligence that performs with the artificial machines. So how does this work? Intelligence is nothing but a human intelligence that we can see. If a person we are seeing it on a daily basis, I can say it's Dr. Raghunath because I know him. I have seen him many times. So if you see me today, and if you don't see me in a couple of weeks, you definitely forget me, because you don't have that particular power or data which can store these many data. But whereas machine will store this data, and it will come up with the computational powers, with the large data sets and novel algorithms for the powerful analysis and diagnostic model to say that this is Saurabh. Such as, that's basic definition of artificial intelligence. Next, what's deep learning? Even though deep learning does a similar objective, but deep learning is the core or building module of AI and machine learning, where the multiple layers of data processing takes place to extract more and more features from the collected data to overcome the challenges which we are facing in the normal ones. Further to that, the artificial neural network is a similar kind of a technology where it's completely inspired from the brain algorithms, such as brain has connected nodes within this one. There are so many inputs such as receptors, such as we can taste, we can hear, we can see. These are all the inputs which everything stored in brain with multiple connected nodes. So the brain functions in multiple ways to understand what is the output. So where do we apply these ones? So just to give you an overview of the application scenarios, you might be aware about tumor detection, foreign body detection, image classification, segmentation, and registration. Also, these technologies nowadays are using for generation and also image transformation. Finally, texture analysis. I'm not saying these technologies are limited for only these scenarios, but there are so many, but just we will talk about this stuff today. So, building block of machine learning. How does a project lifecycle works? First, we have to generate the data. To generate the data, we need to find the data source. Data source is nothing but you might be aware about MRI scans or X-ray scans, where we might come across the broken bones or torn ligaments or something. And those are the things which we capture, and that is called as data source. That will be ingested into the preparation module, where we say that the normal data is this much and the abnormal data is this one. We have to compare the data. That is called as data preparation. We are preparing the module for that. Depending upon the validation and the featureization, we build a model where the model will extract the features and say that, okay, if anything comes similar in the future, I'll say that this is not a normal ligament, there is a torn, or this is not a normal bone, it's a broken bone. That's how we build the model and train the model. Finally, we deploy the module in softwares, and we say that you can detect in future perspectives. So, what's a deep learning is all about, and how exactly they are differentiated from deep learning to machine learning. Deep learning is nothing but it mimics the human brain, which can detect the objects or recognize the speech and translating the language which you might have seen in Google, and making the complex decisions for humans. Okay. Whereas machine learning does a similar kind of objectives, but where it learns from the data and make informed decisions based on what it has learned. So the basic difference between machine learning and deep learning is where in machine learning, a human, such as if I'm an object operator, I will say that this is the normal data. That is called as feature extraction. And depending upon the feature extraction, the classification of the data will be performed and it will come out as the output. But in deep learning, we just have to give the data, it will do the feature extraction on its own, it classifies the data and gives the output. It similarly works in terms of a neuron. Neuron takes input from all over the body and it sends the information to the brain. So the brain computes and says that whatever information is needed, it will give an output at that particular time. So how does this work? How the deep learning recognition system works? So the data source, such as I'll take, for example, it's a simple example. I'll take multiple photos of car, I'll take multiple photos of bike. So I'll input the data, and once the data are inputted, the algorithm will decide if it has 4 wheels and it has a windscreen and it has a bonnet, it's a car. And similarly, features of the bikes are it has two wheels and it has a petrol tank, it has a handle and everything. There are multiple features. So we will put all these features into the algorithm and say that whenever you find similar data set, you have to give an output. So whenever you ask the algorithm to give the output, for the first image it will say it's a motorcycle. For the second one it says car. But for the third, it's neither, because it has a foreign body there. It has a lady on top of it. It couldn't detect that kind of things. That's how the recognition system works in here. Next, what is a neural network? Everyone is talking about neural network. How is it exactly different from the existing ones? So neural network are like 2 examples. First one is a non-vision type of neural network, and second one is a vision related. So first we'll talk about non-vision. Non-vision is something where it's completely related or oriented from mathematical expressions, such as a game of chess or a game of tic-tac-toe, or many other games which are completely related to the mathematical algorithms. So what happens in chess? So chess, there are so many pawns and every pawn has multiple weights. So that queen has 20, where king has 2, multiple pawns has 2, the rook has 10, similar kind of things. And they have legal moves and they have illegal moves. They have checkmates, they have checks, they can possibilities to get out of it. So these all possibilities will be implemented in an algorithm to come up with the novelties. That's why till today there is not a single system which can overcome a human brain, because human brain can think in a multiple ways where a system is not yet capable of that one. That's completely non-vision. So what's a vision related? Vision related is something where you see apple, you see orange, you see pineapple. So whenever you see things, you know the difference between the fruits. Similarly, the algorithm will also know the difference. If something is round and or in orange in color, it's an orange. If something is like in a cylindrical shape and it has trees on top of it, it's a pineapple. If something is in red in color and it's not completely round, it's a bit of oval shape and it has a bit of notch on top of it, and it's an apple. So that's vision related neural networks. So this all helps in multiple scenarios. So how does this work in detail? So artificial neural networks takes inputs from visible input layers, such as in medical field. What happens is whenever there's a tumor detection has to be done, it considers surrounding factors, whether the surrounding factors are true, whether the size, shape, and dimension of that particular tumor are in a regular shape, or region of the tumor detection. So it's all visible input layer. It processes in the algorithm and it generates from the earlier set to the right now generated data set. Multiple layers of hidden layer or computational happens, and the visible output layer is to say that whether there is a tumor stage 3 at abdomen or something. It's just for an example, don't take it seriously for now. So how this convolutional network works. So first one is whenever you input some data such as image, or like for an example now, here is a lady's face. So lady's face can be detected in 2 different ways. First one is edge detection, where the outer bonds or edges of a face will be detected and say that this is a human face with these particular features. There are eye detection. Every phone nowadays has a eye controllable analog system. So that's similar to this one. So next one is a blur system. In blur system, what happens? There are pixels will be generated. Those pixels will be matched with the ultra generated photos, and it will be matched for the output. So these systems can be worked in they're regularly working in for face recognition, emotion detection, voice analysis, object detection for self-driving cars, and many more. These are all like in a real-world example. But what happens within the human body is still a research to be done. So the deep depth of the convolutional networks is like you take thousands of photos, such as you study the multiple theories. When as everyone is around here, doctor, you might be aware about MRI scan will be taken in multiple angles. Why? Because before a doctor has to decide whether there is a 3rd degree torn in your ligament or a 1st degree torn in your ligament, you have to understand the degree of the torn. So you will take multiple angle photos, multiple depth photos, and then you will analyze the heat images as well. So similarly, this is what happens in algorithm as well. It takes multiple photos, it matches with the earlier data set to the current data set, and it performs in so many higher computational levels. It has so many max pooling systems and down samples to come up with the dimensionality reduction given as output as there is a ligament tear. So this is where the one university in Canada has come up with the similar kind of current trends. So here have a look at the video where they have performed this detection of the particular tumor with multiple photos. On the right hand side, what you can see is the photos A, B, C, D, they're all these images captured from this particular sensor and have implemented into the algorithm and told that this is not the actual skin. There is some abnormality. To come up with whether the definition of the abnormality, there is possibilities. So okay, you might say that as I'm saying, there are so many possibilities with these technologies, then what are the challenges associated with this? So problem is that there are not enough data sets in this real world, because every human body performs or every human body behaves or gives an output in a multiple pattern. That pattern is not recorded or has not been recorded so far. It can be done now, and there are so many possibilities in the future. We may never know. So external validation is not possible because most of the practical case studies are house generated. Every doctor will not go for some external validation saying that, oh, this data set has to be matched with my current system. Nobody does that. But if we could do that, then there are systems which can generate from the data sets that will help us in the future. Further, the extensive research and development of the advanced algorithms are needed in this field of urologiasis to outperform the conventional statistical methods. So, what are the future impact of AI in urology? First of all, we'll now talk about urological practice. So, if at all AI is doing all the job, then what's the use of urological practice? If we could do that everything. But conventional methods with compassion, empathy, and communication are still lacking in the AI systems. The caring, that extra care that doctor gives when he's operating on a patient is still, it's never going to happen in an AI system. And it's also a high-level recognition system will always in a human forte. Then what happens with respect to urological training? Whether it will overcome the system, advanced technological trainings. So clinicians, they have to continually update their knowledge base and update their skills to keep up with the technology so that they can improve their knowledge base with the current systems. Also, doctors should actively involve in the development and integration of these technologies into the current practice. Thank you for your time. If you have any questions, please do ask.
Thank you very much, Saurabh, Dhani. This was a wonderful presentation. I think we'll take the questions the last. I will request Dr. Sandeep Gupta sir to again introduce Dr. Mahendra Bhandari sir. So please unmute yourself, Dr. Gupta sir.
Okay. Yes. Is Dr. Bhandari joined us?
Yes,
Yes.
Yeah, Dr. Bhandari, it is a pleasure to have you with us on this program. And I know you are personally interested in this field of artificial intelligence since last 10 years. And we have personal interaction also on this topic. So it's a pleasure to invite you to give your perspective about the role of artificial intelligence in uro-oncology. Dr. Bhandari needs no introduction, and currently he is the Director of Robotic Surgery and Research and Education at Vetiguti Urology Institute at Henry Ford Hospital, Detroit. Dr. Bhandari, please.
Thank you, Dr. Gupta. It's great meeting you. And I will share my screen. I apologize. I was preparing for it for tomorrow because so many webinars. Please apologize for the sloppy thing, but it would be a pleasure to share my views. Can you see my screen now?
Yes, we can see you.
Okay. So I think I'll begin briefly with my disclosures. We have a funded grant from National Science Foundation, and we have been working in this area actively. Now, having heard the previous talk, I think my job would be to come to the brass tacks, where the rubber touches the road. What should we expect with artificial intelligence in urology or uro-oncology in years to come? How it is going to impact our practice? How it is going to impact us? And for that, I would like you to agree with me what is the current status. And I am sure you will. Can you see this?
Dr. Bhandari sir, please make it full screen, sir.
Okay, I'll do that. Just a minute. Can you now?
Yes.
Yes. This is a surgical video of a surgery being done, and I would like you to observe this. See, just a minute, it's not the correct. Just give me a second. Yeah, this is the correct video. This is the current status of surgery. A very gentle surgeon. He's dissecting the tissue as we all do. And he's very gentle. All those who do robotic surgery would know. Just watch this video for a few seconds. And I'll be able to prove my point with this. And all of you, being very, very prominent active surgeons, would agree with me what I'm wanting to say. Now, this is the current status of surgery. Surgery is reactive. Surgeons and urologists are no exception. We are good at creating problems and solving the problems. Surgery is reactive, not responsive. The predictive value of surgeon is almost nil. However, you may prepare with the reference points of CTs and advances in imaging, when you begin in every surgery, you are covered under a cloud of uncertainty. And that's where, if I see artificial intelligence in surgery, is going to do one thing, if you see, besides all other things, is bring more predictability to surgery and the processes of surgery. Why it is important to have a predictability? Because if you would like to, if you know that this is a probability which is very high probability, then you can preempt your actions. Second thing is, whenever we are talking of surgery, it is linked with the surgeon experience. And if I say that a learning curve for radical prostatectomy, benchmarking erectile dysfunctions with the best results in the world, has 300 patients through a paper published by Ash Tiwari in British Journal of Urology, then all of us inside the four walls of operating room have to agree that 299 patients have suffered in your heads with the poor quality outcome. Not that they have not died. So the question is here. So unmet need in surgery is, this is a very recent slide, which I heard a symposium. What is the unmet need of surgery? Oh, something is happening. It's not letting me do that. Lowest quartile surgeons have 36% higher complication rate, of which 10 are durable complications. Surgery does not go as planned in 36% of cases, and one of them will not recover. Eventless patient recovery needs a workforce of 60 to 70% to implement the plan surgeon does. Now, with these three parameters, you would realize, this is Gary Gutthard's his own statement on May 2020 in a symposium on robotics. And this is the hard data from Intuitive. So you can imagine that a lot needs to be done to make surgery error-free. And there are two areas which we can look into. One of them is the area of computer vision, which was alluded by the last thing. And my major work is in the area of computer vision. And all we are trying to do is to make surgery transparent. We work particularly on kidney, and we have narrowed it to kidney hilum. And our model is live donor nephrectomy in laparoscopy, because we did not want to get into the robotic space for several reasons, but it would be the same. And we build computer vision models for renal hilum. To tell you what exactly we are wanting to do is that you would be able to see undissected hilum like in a car, what you see in automated car or Tesla or Waymo, is that everything is in the under the vision of the cameras and the sensors or the lidars. Similarly, we want that surgeons should have real-time submersive feel of all the structures undissected, even the smallest vessels. And then you can take a decision whether this vessel needs to be salvaged or sacrificed. But it is not blind digging. It is no more surgery tracing gonadal vein to the renal vein or looking at the pulsations intuitively or histotically where could be the renal artery. As an experienced surgeon, Dr. Gupta, Anup, or Jinil, I'm sure all present here, don't see it as a problem. But when you look your 25 years or when you did the first hilum, you would recall that how much it is a problem for the surgeons. Then the next thing, next question, I know sensitivity about my time, so I'll talk of the next thing. When you are talking of predictability, predictability is not needed only in surgery. Predictability is needed particularly for uro-oncologists in knowing the expensive drugs with high amount of toxicity, very high toxicity and subjective improvement in few cases. You would like to know before 6 weeks of chemotherapy whether X patient's genomic structure or the mutations would respond to this. Now it is all possible in precision medicine that we can predict which patient is going to respond. You don't have to wait with the money of the patient, and also there is a predictive way. Smaller things like this. We worked on mimic data, which is publicly available data set, and we did it's a huge data set of 48,000 cases. And we did that database, and we found we predicted 7 days hospital mortality. 90% the model performed well. And we published this paper. Similarly, we published a paper on partial nephrectomy on which some of you are on the authorship because it's collaborative paper of BCQI. And we published 7 papers to realize that why this is not going further. It's the right time to publish any paper on predictive models in urology journals because they are looking for such papers. But I'm grossly dissatisfied because ultimate objective is not to tell your models are performing above 90%, but to make them as a clinical practice tools. And the biggest problem in turning them into clinical practice tool is what I would like to just spend a couple of minutes to tell you that what exactly happens. The way the models are built, there is known as after you train the models, first is the data. Now, the data is not the data of relational databases we are used to. It's a data which should have these characteristics. The volume of the data has to be large, not 2,000 patients or 5,000 patients. We are talking of 48,000 patients. We worked on mimic database with 1.75 million data points. Then the variety of data, because we want to cover all the variability. Then the velocity of the data. Velocity of data, that's why we worked on ICU data, because ICU data has timed events. Blood pressure is taken every 15 minutes, temperature is taken, urine output is recorded. So it's not the periodic data of one follow-up after 6 months. You have to have a periodicity of data. And then the quality of data is very important, that there has to be variability or consistency over time. And the last thing is veracity of the data, means data should be trustworthy. You cannot expect the models to do well if the data is not from the trustworthy sources. Now, it's not garb in, garb out. There is one more mindset a urologist will have to change. Here we work on known variables, that we have 5 or 7 known variables and we work on them. But here we work on hidden insights. So we take as many data points as possible, whether they are correlated or not, but still we need to see that so the biggest point which I'll emphasize is you have to change your mindset for big data. And let me tell you, with my 2 cents for last 8-9 years, this is not going anywhere till the urologists get involved, because we are sitting on gold mines and we are not aware of it. You don't have to learn the language R and build the models. All you need to do, because there are PhDs who are itching to do this for you. Only thing you need to do is get more involved with the big data, develop a culture where you can really do that kind of thing. So help these people to do. Now, one point I would like to tell you, that why the mimic thing we could not turn into a tool, clinical practice tool. And the reason for that was that the mimic was a one-time database, publicly available database. We had to qualify, do a test to get that database access. But we wanted a data which could be redeployed. The model could be redeployed in clinical practice tool. And here we ventured on doing BCQI, which is with 25 centers. We started doing, and we published it in British Journal of Urology. And we were so disappointed because we could not deploy that model, because we added 300 more cases and model collapsed. And our technical people, and we spent a lot of time that with more testing data, why should a model which was performing 87% accurately predicting intraoperative complications in robotic partial nephrectomy should collapse? And then we found out that the center which was contributing largest database stopped contributing the data. So this taught us another lesson, that it is very different that AI is working successfully in business intelligence like Amazon, or Tesla models performing 99.9999% accurate, because these people are gaming for that matter, because they generate their own data. Every car is a computer which is feeding in millions of data points. When Tesla released the package for lane changing, there were 9.5 million data points of lane changing, which covered almost 99% of variability. Now you can imagine how far behind we are in doing that. So what I would like to request you, that get into the data is the domain of the urologist, which he has to do. And second thing is, don't build models till you have looked into the totality of the model cycle. Means a model is built, data is cleaned and processed or curated. Then the model is built. Then the model is trained with the data, and a part of the data is used for testing the model. Then the model needs external validation, and then the model needs to be deployed. It would be almost very different than your nomograms and the risk stratification tools, because why they have failed is because there is no ease of implementation for the clinician. But we have a solution that moment this model is performed, we would, moment these data points, 15 or 20 data points are available, model, your computer will predict as soon as the patient comes that there are 99% chances of this patient losing a kidney, if we have that kind of database. So I think the point which I want to make is, as regards to my computer vision model, let me tell you where the technology and where we are. Kidney is a very favorable organ. We have been able to build the model successfully to identify renal artery, renal vein, spleen as a landmark, and we would be able to do for other structures. Our model performed exceedingly well. And with more data, we are talking of only 5,000 images we have used now. The next step is that since we want a real-time immersive technology of augmented reality, we have been able to do it through the HoloLens, but that is not acceptable for the surgeon. So there are two steps which the whole world is struggling for a long time. One of them, because the soft tissue like kidney and liver have movement, so much of movement that the virtual model has to match with the real model. And this is the process of registration. What you see. And next larger problem is that tracking of this organ. And tracking means that with every touch you do the kidney or vessel, the kidney volume changes. And these are two problems we solve. I think we will have some answer. There are lots of tools which are coming in the market, like Iris IA. I was in the Mount Sinai, and Ketan Badani is using them, which is superimposition tool. But mind you, the difference is they are still reference tools on your panel. They cannot be superimposed directly. Immersive technology is still lacking. I think I can go on, but all I would like to sum up by telling that the value of prediction, don't undermine it. Surgeon experience is the only deciding factor for the complex surgery, number 2, whereas surgeon experience of the individual surgeon is minuscule. Dr. Menon might have done 10,000 prostatectomies, but which is a minuscule on 5 million prostatectomies that are available globally. Previously, we did not have tools and means to use that data and the best practices. Now we do have. And the second thing is that you have to involve, youngsters have to involve and develop a culture of collecting data, because Intuitive or Auris would not be able to make robots until the urologist or the surgeons provide him with the kind of data, because technology is there to make the models. I think I'll end here. Thank you, Janil, and we will come back and take questions whenever your program permits. Thank you very much, Dr. Gupta, for your kind attention.
Thank you, Dr. Bhandari, for your very thought-provoking and exciting talk to give us the idea where we have to go in future. And because of shortage of time, we will move on to the next lecture. I request Dr. Anup, please introduce Dr. Vasant Venugopal.
So we invite the next speaker, Dr. Vasant Venugopal. He leads the Medical Imaging Division, the Center for Advanced Research in Imaging, Neurosciences and Genomics. He's a senior consultant radiologist with Mahajan Imaging. He's got 10 years of experience as a consultant radiologist at several hospitals, and also a faculty position at the Rana Medical College, Delhi. And he has got extensive work in AI. And as a part of the clinical role, he also leads the application of newer advanced imaging solutions to clinical practice across all centers of Mahajan Imaging. So I welcome Dr. Vasant Venugopal to give his talk. So over to Dr. Vasant Venugopal.
Thank you so much, everyone. And I'm just going to share my screen. Can you all see my screen?
Yes.
So Dr. Bhandari's talk, which just preceded me, is probably the most inspiring talk on AI I have listened in the past 3 years from a clinician. Compliments to you, sir. I'm so much kind of impressed with the way you presented the concepts. In fact, midway through the talk, I have decided that I will tweak my presentation in such a way that I'll just talk about. I'll show these slides for 5 minutes, and the rest of the 5 minutes I'm going to demonstrate to you the work which we are doing at Mahajan Imaging and Caring to bring the AI solutions to clinical practice. So without wasting much time, sir, I'm just going to just briefly touch upon some theoretical construct, and then I'm going to just jump on for 5 minutes to show what we are doing at Mahajan Imaging. So I'm a radiologist, and I've been involved nearly full time in development and deployment of AI solutions. We have been working with several companies for the past 3 years. And just some theoretical constructs which to build upon what the first speaker talked about. We all have been hearing about this deep learning and artificial neural networks for quite some time now. What has happened recently is, which has enabled this technology to see such tremendous success, is that the improvement in the GPUs, the technological advancements in GPUs have enabled the process of building algorithms more robust, and using them in clinical practice has become a practical consideration now. That's what has changed recently. And what's the offering that DL is, the technology of DL, what's the promise the technology DL is offering in cancer screening is, I'm going to present this from a pure play radiology perspective, because that's the area I work on very extensively. From a radiologist view, the DL offers several promises, including the detection of a lesion on an image, characterization of the lesion, whether it is tumor, benign tumor, malignant tumor, what's the prognosis it's going to have, all those things, and also monitoring, longitudinal monitoring of those lesions. Everyone will agree with me that even though the same radiologist reads the scans again and again, the way he's going to measure the lesions, present those findings are going to be different each and every time. The standardization, the promise of standardization which such technologies offer to us is very incredible. And also, we all know that the current domain of oncology practice involves, it starts with radiology, goes to pathology, and then with a tissue diagnosis, you make a decision of whether to maybe in some instances of early stage of prostate cancer, observe or intervene or do surgeries. All those, as Dr. Bhandari rightly said, we are being so far reactive to these things. We have never taken a proactive approach. We have never done a midway course correction based on the inputs from those different imaging parameters we have. That kind of possibility is what deep learning is opening up. Practical consideration, practical points. As far as urological imaging is concerned, the prostate cancer detection on MRI is one area where there is tremendous progress. There are, as we speak at this point of time, there are 5 FDA-approved AI algorithms that can automatically process MR images and can either identify prostate cancers, characterize them, or even quantify the tumor sizes from different companies around the world. And I'm just going to skip these slides just to save some time to show what I have been doing. And there are several studies which have been done and which have shown that there is a good kind of accuracy in these algorithms. One of the metrics, accuracy metrics, which are used to predict or present the performance of the algorithm is called area under ROC curves. In this study, it's been 0.87 to 0.84. It's not to the extent of other body parts like in a chest X-ray. The AUCs have reached 0.95, 0.96, but still the prostate or other cross-sectional imaging studies need to go a little way ahead to reach that kind of accuracy. That's where the collaboration between clinicians and radiologists with developers is very important. As Dr. Bhandari rightly pointed out, we need to be working closely with them to bring this to the level which is acceptable for a clinical practice. We have validated several such algorithms in our clinical practice. One of the algorithms which we validated can automatically kind of estimate the prostate gland size on MRI scans, and we used a metric called DICE score to estimate the accuracy of those measurements. That DICE score is very good in this particular algorithm. It is around 0.92. And one thing which, as radiologists, we discuss among ourselves, we don't talk about is the promise these solutions are going to, are offering in improvements in the hardware of radiology equipments. You all, being robotic surgeons, you are very well familiar with the way the precision of the surgeries improved with introduction of robotic robots in your practice. Similarly, there are several research projects that are being conducted by leading healthcare providers, one of them being Philips Healthcare, working on kind of automating the entire process of acquiring those ultrasound images. One of the problems with ultrasound scans is that the variability between the scanners, the experience, the radiologist, the one who is acquiring those images, depending upon their difference in the experience, the images, quality of the images might differ. That's one variability which can be very well addressed by these solutions getting automated. And the other area is the POCUS, right? The point of care ultrasound solutions. This butterfly ultrasound solution is now available for clinical use across the world, not in India, purely because India is heavily regulated. The ultrasound machines in India are heavily regulated by PNDT regulations. We may not be able to see this in probably a foreseeable future in India, but given that the regulations are changing with the advancement of technology, I hope to see such solutions in clinical practice where you have a handheld ultrasound probe, and that probe can be connected to your mobile device, and this device will give you real-time feedback on where to position the probe to acquire an image. Say you are in your OPD and you want to just check the prostate size for a patient who has come to your clinic. Right now you have to send him for ultrasound, wait for the patient to come back just to know the size of the prostate gland. With such kind of tools, you can probably place the probe on the patient, and within a couple of minutes you'll be able to measure the prostate gland size, and the treatment offered to the patient can be initiated right away. So that's the promise this technology is offering. I will take a couple of more minutes just to show what we are doing at our centers. I represent Mahajan Imaging, and Mahajan Imaging, as many of you must be knowing, is a leading radiology services provider in Delhi NCR region. And Caring is a research division of Mahajan Imaging, which is incubated in the Mahajan Imaging, through which we are trying to validate many of these AI solutions for our clinical practice, and also trying to bring these solutions to hospitals around the world. So in this journey, we have developed a platform. Are you able to see my browser screen? The platform you're able to see, right?
Yeah,
so this, correct. This is the platform which we have developed. This platform is called Carpal, Caring Analytics Platform. What we are doing through this platform is we are integrating several AI solutions from around the world into a single place, to a single interface, and deploying them at radiology clinics and hospitals around the world. As you can see in front of you, there are at least 30 AI solutions which we have integrated in a single platform, and which addresses different body parts, not just a breast or chest. As you can see here, head, chest, breast, urology. We also have this prostate solution integrated into our platform. And this platform, we are connecting this platform into the radiology departments of hospitals, and we are providing them access to these solutions. They can easily hook on these systems to their this platform to their existing PAC systems or equipments like MR, CT scan, and ultrasound, and start using these solutions in their practice. So as Dr. Bandari described during his talk, the life cycle of an AI algorithm is what is being shown in this left panel of the platform. It starts with data set. You have to pull in data, and then you have to provide annotations on the data, where annotations is where a radiologist or a radiologist technologist looks at those images, marks those areas of interest, and then it goes into the training part of it, right, where these data sets and their labels are fed into deep learning algorithms and trained. And once they are trained, and the algorithm which either the center develops or the center integrates from a third party can be easily tested using this testing pipelines. As the first speaker illustrated, there are several types of deep learning algorithms. The classification algorithm is the most commonly used algorithm, which is simply like you throw an image and it says whether the image has a cancer or not. That's a classification algorithm. You can easily test that algorithm on this platform on your own data set. The radiology centers at your clinic can easily test those solutions on their data sets, and they will have these statistical tools to measure the performance of those algorithms on their data set. So these are I can talk about this platform for lengthy period, but given the time limitations we have, I'm just briefly touching upon the features. Here, what I'm showing you is a validation project which we have done. Just 1 minute. Just 1 minute, sir. Yeah. Just 1 minute. I'm just closing. Once you have tested this, you can deploy this solution on your real world data. So I'm just stopping here. So maybe I can talk more about this during the Q&A session. Thank you so much for providing this opportunity.
Thank you very much, Dr. Venugopal. I will request Professor N.P. Gupta sir to make his expert comments.
Before I give any comments, anyone like to put one or two questions to the speaker?
We are all shooting the time, sir. So just one comment was there from Dr. Murugesh Manoharan that why it is artificial intelligence, because artificial always feel like there is a fake intelligence. Why we should, is it a right term? So any comments? After that, we'll probably, if there is no active questions, we'll discuss rest of the thing to last part.
So Dr. Gunil, I just want to ask one question from Dr. Bhandari. Dr. Mahendra Bhandari, sir, I just want to ask one question if you're there.
Yes, I am very much here.
Sir, what we lack in robot is the tactile feedback. Do you think the AI and CNN, the ML algorithms can bridge that particular lacune and we can have the tactile feedback because of this new technologies?
See, tactile feedback, Anup, all those who have used robot don't talk much about it because they've got used to the perception. If you see, surgery, we use 3 senses. We use all the senses. We even use smell. Main sense is the visual perception. In open surgical era, the tactile got dominance, which suddenly was collapsed when the robot came into. And there are new robots with haptic feedback. Most of the new robots are bringing haptic feedback. But I don't think that would be an issue to solve. The major problem to solve is how do we make surgery transparently visible to you moment you put your port in? That is the challenge. So tactile sensation, I think Dr. Gupta would be able to comment on. Do you miss tactile sensation after getting into robotic surgery?
No, Dr. Bhandari, you are right that the visual cues what we are getting through the robot and the magnification, we don't miss the tactile sensation, in the robotic surgery. So anyway, that is a very short coming of the robot, but that is overcome by the visual cues. And I like to thank all the 3 speakers for their excellent talk and vision, what they have given to us, that future is there in artificial intelligence, and we all must contribute. And starting the database, I think so that is one thing which Dr. Bhandari is trying very hard to collect the data from this, from all over the world, actually, I will say, because I know how much he is working in this field for the data and the importance of the data. So this is the first step, and we should think in our society also how to improve the data in the Indian context, I will say. Okay, thank you very much. Because of the time, we'll move on to the next session.
Thanks to N.P. Gupta sir and Anup and Bhandari sir, Saurabh and Vasant. We'll move on to the next session, that is section 2. Dr. Santosh and Dr. Vedant, kindly start the next session and invite the speakers.
Yeah. Thank you, Gunil, and invite Vedant also to this session. This session is on pathology, genomics and radiation oncology and AI. The first speaker is Dr. Veena. Is Dr. Veena there? Yeah, Dr. Veena is the head of histopathology and digital pathology at HCG Cancer Hospital, Bangalore, with special interest in Uro-Oncology, and she will be today speaking on deep learning in uropathology. Dr. Veena, the stage is yours.
07. Veena. 1, 2, 3.
Dr. Vinith, kindly mute, yes.
Am I audible?
Yes, now you're audible.
Yeah. Good evening, everybody. At the outset, I would like to thank SOGO the organizers of this unique webinar, Dr. Raghunath sir for the invitation, and also Dr. Ginil for the excellent coordination. So let me just straight away start with my presentation. So we pathologists face a lot of challenges in our day-to-day practice. If you see the WHO 2014 publication, it clearly says that the incidence of cancer is going to increase by more than 70% by the year 2030. And we are already seeing this increase in cases in today's practice itself. It's not only the increase in the numbers, but also the complexity of the cases that are increasing, that are making the pathologists resort to additional investigations for arriving at a diagnosis. Across the globe and India, particularly in India, we have lack of subspecialist uro-oncopathologists, and most of the diagnosis in uro-oncopathology is being done by general pathologists. And there are several publications which have compared the inter-observer variability between the general pathologists and the uro-oncopathologists, and this variation is as high as 20 to 25%. And there is one publication in India itself way back in 2011 that was published in the Indian Journal of Cancer, where they compared the reports by the general pathologists with that of uro-oncopathologists, and they said that the agreement for Gleason's, the diagnosis and the Gleason scoring was only 48%. So this means to say that there is a huge impact on the patient management because of the increasing cases, the complexity of the cases, the lack of uro-oncopathologists, and the inter-observer variation, which are causing a delay in almost 41%, and thereby significantly impacting the patient management. We are in an era of precision oncology where there is a demand for evidence-based diagnosis, and the diagnosis needs to be quantitative, particularly in the practice of uro-oncopathology. And there is also so much happening in the biomarker research, the genomics playing a significant role in targeted therapies, etc. And this is where artificial intelligence and the machine learning algorithms are trying to pitch in and support the pathologists. Breast and prostate has been two organs where most of the data scientists are interested, and they have been working on designing algorithms, the models to predict and to not only help the pathologists in the diagnosis, grading, scoring, quantification, as well as in predicting the treatment outcomes. And Dr. Nikhil Vasudev is today here with us, and this is his wonderful article that actually takes us through several of these milestones. And all these articles work on different platforms, like some work on the linear regression, some work on CNN, the convolutional neural network, some work on artificial neural network, and some work on the random forest, the ensemble techniques, etc., etc. And they have shown very good AUCs, the accuracies of almost 0.85 to 0.99%. So does that mean that we implement this in our clinical practice? So I would also like to bring this one particular article from Dr. Pantanovis that was published in 2020, where apart from the diagnosis, the quantification, scoring, he also looked at the use of artificial intelligence machine learning algorithms in the detection of Gleason's grade 6, the score 6 and 7, which are the dilemmas for pathologists, and also whether the model would predict the help in the interpretation of the atypical small acinar proliferations and the interpretation of perineural invasion. So he evaluated this model, whether it is able to predict all this. And this model again gave an AUC of almost 0.94 to 0.99%. So does that give us confidence to implement this in our clinical practice? So we still don't know, because as I said, all these algorithms are developed on different technologies, and how do we compare each of these and say which is the best? So we still don't have an answer for that. So just to bring one particular article for your attention. So this was an article that was published in 2021, and this is a study based on the 100 cases that were evaluated by a model based on the convolutional neural network, where they evaluated 100 cases of truss biopsies of prostate using this particular model, and they showed that this model is able to predict the Gleason, diagnose the prostate cancers, predict the Gleason score, Gleason's grade, as well as quantify with an accuracy of almost 0.99. And this, the only limitation with this algorithm was that it failed to identify atrophic glands, adenosis, and also post-atrophic hyperplasia. The algorithm also picked up 3 cases which were missed by pathologists, mainly the Gleason's grade 1. So important thing is that at the patient level, this algorithm did not miss cancer. So it was able to predict all the cases and diagnose all the cases that had carcinomas. Interestingly, this algorithm actually reduced the time that a pathologist takes to interpret a case by almost 65%. Is this enough for us to implement artificial intelligence, machine learning algorithms in our clinical practice? No, we still need much more clinical validation studies. So that has been the application of AI ML in prostate cancer. So now let's have a look at the application of AI in renal cell carcinomas. There are very few studies that have been done, unlike prostate. Whereas in prostate, not only from diagnosis, people have also worked on the predictions and predicting the recurrences and metastasis, etc. Whereas renal cell carcinomas, there are hardly any work that has been done. And this is mainly based on several models which work on, again, linear regression, support vector machines, random forest, etc. And mainly they have looked at the nuclear features. So I need to grade the tumors as either high grade or low grade based on the nuclear features. And they also have got a very good AUCs, the accuracies of 0.997, etc. So the limitations of the application of renal cell carcinoma, the application of machine learning in renal cell carcinoma has been that these have been evaluated only on the nuclear features, particularly the Furman grade. So how would the algorithm perform with ISEP grading system? And these are actually semi-automated ones where the pathologist has to identify the region of interest or the area under the curve and query the algorithm to interpret it. Now looking at the application of artificial intelligence in bladder cancer, so not much work. There is only one that is interesting, which actually gave an automated diagnosis on bladder cancers and compared that algorithm against 17 pathologists. And among the pathologists, there was a very high inter-observer variability, whereas the algorithm actually had an accuracy of 0.97. Brio et al. Actually looked at tumor burden as a pattern for interpreting the worst prognosis in bladder cancer. So as we talk about the application of artificial intelligence and machine learning showing high accuracies in urogenital pathology, are we convinced that we can implement these algorithms into our clinical practice? That's a big question, because there are several limitations that these models do carry with them. One is that there is an investment that is required. So we need to have digital pathology scanners for the generation of whole slide images for these algorithms or the models to be applied. So a second thing is that we need to have large number of cases, because these algorithms suffer from what is called overfitting. That is, these are actually trained, validated and tested on the same sort of set of data. So when we apply this to a different set of data, are they able to give the same accuracy? So that's again a question. The pathologist has to spend a lot of hours in annotation and interpretation, in validating and testing these models before it is put into clinical practice. And again, as my previous speaker spoke about, IT cost is something that requires a thought about this particular implementation. Some algorithms are developed on particular image formats. So when we apply these algorithms into another scanner which has a different image format, what would be the implication of that? So what would be the accuracy? That is another thing that we need to look into. The speed of the algorithms, how fast they are able to interpret and give a diagnosis, that is something very important, because if it is taking a long time, definitely the pathologist would not like to go back and query the algorithm rather than do it on the microscope itself. And we all know that there is heterogeneity of cancers, and so is the heterogeneity in these different models, because as I said, some of these are developed on linear regression, CNN, etc. So how do we compare these particular models? We still don't have an answer, and which one is best? So we still don't have an answer for that. So as whole slide images and HND images and even unstained images are forming a base for the interpretation of genomic markers, does ethnicity influence the outcome of these algorithms is again a question. Overfitting, as I said, because these algorithms are developed on one particular data set. So if we apply it on another data set, how will be their performance? So we still don't know. And ethical and regulatory issues, there is still no clarity on application of machine learning in pathology. So does it mean that we should not apply these, or we should not explore these algorithms in a routine practice? Definitely not, because they do carry a lot of benefits to the pathologist. They accelerate the pathology diagnosis in a busy laboratory by classifying the diagnosis as either benign, suspicious, or malignancy, so that the pathologist can concentrate on more on those cases which are classified by the algorithm as either suspicious or malignancy. So thereby they help the pathologist in making an accurate diagnosis. Particularly, it helps the general pathologist whenever there is a dilemma, and also it helps in providing them support in the interpretation of cases.
Veena, you have only 1 minute left.
Done, it's almost. So it reduces the inter-observer variability. And for surgeons, it definitely helps in making a preoperative decision by quantification and other histological features that can be interpreted on the biopsy itself. And as I always say, that pathology is now a bridge between radiology and genomics. So these algorithms are bridging these two disciplines, thereby helping the practice of precision medicine. So as a pathologist, what would I look at with these machine learning algorithms in the future? One is that these algorithms have been developed on a particular histological subtype. So probably we need to have algorithms that would help us in the diagnosis of much more different different histopathological subtypes in the prostate, kidney, and bladder tumors. There is so much happening with the tumor microenvironment that being taken as a target for the targeted therapy. Now we need to have algorithms which can help us in predicting tumor microenvironment, particularly from a point of predicting the recurrence and prognosis. So much is again happening in genomics. So whether these algorithms would help the pathologist in predicting the genetic markers or genomic signatures on the H&E images and unstained images. So that would actually help the patient in reducing the cost as well as save the time for the patients. We have been always looking at kidney, the bladder, and the prostate. So we need to have algorithms that would also help in other genital systems like the testis and the penis and other in the female genital system. And as histopathology is a bridge between radiology and the genomics, so we need to have robust algorithms which would support us in the practice of pathology, particularly in the era of precision diagnosis. So just to conclude my talk, artificial intelligence, machine learning, deep learning are very interesting, fascinating, and challenging for a pathologist. But are we in the right era for clinical application of these is a question. But I think this definitely carries the future, with more pathologists opening up to explore this technology and implement that in the clinical practice. So I think we are not so far away from that era. But we need to have very robust clinical validation studies before we do that. So thank you so much.
Thank you, Dr. Veena, for a very lucid and very, very nice presentation. For the want of time, we will move on to the next speaker, Dr. Mithua Ghosh. Is Dr. Ghosh here? Dr. Ghosh is the Director of Clinical Diagnostic at Strand Life Sciences and Head of Department of Molecular and Clinical Genomics. She has several publications and has done a lot of research, and she will be speaking on AI and machine learning in Uro-Oncology and application in clinical genomics. Dr. Ghosh.
Thank you, sir. Good evening, everybody. Am I audible?
Yes.
Yeah.
Yes, you are audible. Yes, you are audible.
Yeah. Thank you so much for the organizing committee, Dr. Raghunath and Dr. Ginil, for giving me the opportunity to talk in this forum. Although I'm not an expert in artificial intelligence field, thank you to the respected the faculty, other faculties as well. So my topic is application of AI and machine learning in uro-oncology, specifically in genomics field. So I would like to start with this slide that in a regular journey of cancer treatment, generally an oncologist or a clinician faces several challenges. He has different milestones of early detection of the cancer, understanding of the disease and its subtypes, and based on those subtypes to decide on the tailored novel therapy, whether the therapy is a radiotherapy or surgical therapy or any chemo or radio or any hormonal therapy. And then follow up the patient for to see whether the patient is benefiting from the treatment or he has no response or there's a recurrence. Now, while doing that, he has different milestones. With these milestones, he has different milestones of good prognosis, monitoring and surveillance, improved survival, and definitely patients' quality of life. However, the challenges in cancer treatment or in the journey of cancer treatment is heterogeneity of the cancer, microenvironment of the cancer, which is very diverse. No two cancers in two different patients are same. Even two cancers in the same patient is different. Organ-specific metastasis, that is, a cancer can go to different organs in different patients, toxicity of the drugs, and the drug resistance. There have been multiple progresses, and we know there have been remarkable progress in the precision medicine and immuno-oncology, using different technologies like genome-wide sequencing, emerging biomarkers, understanding of tumor microenvironment and tumor immune microenvironment. There are technologies, blood-based technologies for monitoring and surveillance of a cancer upon your treatment. There's a huge development in radiomics and radiogenomics to find out what is the right dose of radiation to be given so that we don't undertreat or overtreat a patient. And these all have led to big data analytics, and where AI and machine learning play an important role. I won't go into details because Dr. Saurabh has already talked about different AIs and the concept of AI and how it works. But I would like to draw your attention to one, it's a kind of consolidated slide on one study where which has been published, and it's a landmark paper in British Journal of Uro-Oncology, where a systemic review of kind of all the literature published in AI in Uro-Oncology from 1994 to 2018 have been studied, and there are 111 articles already published and studied. So what people have seen that AI has huge utility in, especially in Uro-Oncology field, for using radiomic imaging and ultrasonic echo data to improve and automate the detection and outcome prediction. Utilizing digitized tissue specimen, which Dr. Veena has already talked about, AI has played an important role in cancer detection. Combining patient clinical data, biomarkers, gene expression to assess disease diagnosis and outcome prediction. And then people have used video-based robotic automated performance matrices to evaluate surgical skill, as well as also planning other radiation therapy and treatment. And the conclusion from this study has shown that 72% of the study concluded that AI is superior in diagnosis and outcome prediction, and it is more explorative in analyzing the large data cohorts, and it facilitates in evidence-based and individualized patient care. Now, Uro-Oncology, as a very forward-thinking surgical specialty, has set up an exemplary track record in adopting new technologies, and I think it is uniquely placed to adopt AI. Now, let's see how AI helps in specifically in prostate cancer genomics. Sorry. So prostate cancer, I think, is an ideal candidate to benefit from AI, because all the diagnostic protocols or approaches, including imaging, including mapping of biopsies, analytics, robotic surgery, and mature genomic sequences have been already established. So now, how AI can help? AI can help in diagnosis, like in screening, pre-biopsy diagnosis, histopathology diagnosis, and also analyzing the whole genome or the transcriptome data, which leads to a better prognosis. And AI can also help in, as I will show you some examples, in risk stratification to understand the residual cancer burden, in analyzing the metastatic prediction and identification, and some survival data prediction. Now, this all would lead to a precision drug design and precision medicine, also determining the adverse effect prediction and how a patient is responding to the drug. Now, currently, as you all know, that in prostate cancer, decision-making mainly relies on certain markers like PSA, Gleason scores and grades. But as we all know, cancer is very heterogeneous, and prostate cancer is not an exception. The biological behavior is so heterogeneous and significant that a major proportion of patients die with the disease rather than because of the disease. So it's very important for us to understand the molecular and genetic structure or the genetic spectrum of the disease, and this can be enabled by high throughput genome sequencing like whole genome or whole exome sequencing, which gives us all the biomarkers for risk stratification and decision making. Now, how AI can help here is AI can analyze large volumes of radiomics and genomics data, identify a trend, which is called a gene or a gene signature or a molecular signature, which is responsible for disease characteristics or features. And this enables us to understand the aggressiveness of the disease, grade of the disease, local staging, prediction, radiotherapy plan, and prediction of biochemical recurrence, which ultimately enables us to understand whether a cancer will metastasize, whether it is becoming a castration resistance or androgen resistance, or an important pathway aberration, which is HRR pathway aberration. But I must admit here that in genomics, there have been the application of AI in genomics is still at a nascent stage. There are very few studies in prostate cancer. The 3 study and the 3 tests which very in a broad way use AI is Decipher, Polaris, and Oncotype DX. Decipher test is predicts 5-year metastasis and 10-year mortality data using a 22 genomic classifier, which is from RNA expression from either prostate biopsy tissue or radical prostatectomy. Polaris also is the same type of risk stratification. We are all aware of Oncotype DX, which says risk stratification to hormonal or chemotherapy, and very popular in breast and prostate cancer. Machine learning has access to bank of data and prediction, and it outperforms the clinicopathological data. Now, a very recent study by Lee et al., which is also a landmark study, he has shown AI algorithm or developed an AI algorithm to predict the treatment side effects. So he has shown that patterns in single nucleotide polymorphism, that is single gene mutation, it worsens, it's correlated to the worsening of urinary symptoms post radiotherapy. AI is now playing a major role in organotropism. Why prostate goes to brain, why prostate goes to other organs, why renal goes to other organs, what is the reason of organotropism. So as Dr. Bhandari said rightly, that right now we need data. We need more and more data, which is volume of the data, velocity of the data, and authentication of the data to develop AI in genomics. Similarly, in renal cancer, there are certain studies, but not much. The clinicopathological risk stratification prediction models are there, but there are certain challenges, because some of the renal cancers have a very complex pathophysiology, and these models don't match these algorithms. So more biomarkers, multiple biomarkers, more advanced genomic testing, more adoption of genomic testing by clinicians will enable us to develop this database, the data consortium specifically for India and Indian patients, which we can again apply for developing our algorithms for these purposes. Lee et al. Recently had a 15 gene signature and AI algorithm to predict risk and PFS, that is progression-free survival. Using ANN prediction model and 3 genes, FOXC2, BAP1, and PBRM, authors have predicted the synchronous metastasis, recurrence, and cancer-specific death. So work is going on, but much has to be done, I believe, because we need to create more data, we need to generate more data, and the young generation has to be very active in developing this database so that that can be used for developing AI algorithm for proper diagnosis at the right time, and right drug to the right patient at the right time. However, there are a lot of challenges. Why it is still at nascent stage when it comes to genomics, because of the tumor biology, heterogeneity of the tumor biology, requirement of large data set, as I told you, large, very authentic data set, lack of high quality annotated training data. All these are somewhat kind of challenges, but I'm sure in coming year, we will get over these challenges, and with high throughput genomic sequencing, we will be ready with developing the database which will be used for genomics. With this, I would like to thank the forum, and I'll be happy to take questions if there are any.
Thank you, Dr. Ghosh, for that very lucid insights onto the genomics and urological cancers. I hand over the proceeding to Dr. Vedang now. For the want of time, we will proceed and take a couple of questions in the end. Vedang?
Yeah, thanks, Santosh. May I now invite Dr. Haridas Nair? to talk about the role of AI in radiation oncology. Till now, we seem to have more questions than answers. And let us see if Dr. Nair can provide us some answers that we are looking for. Dr. Nair, please.
Thank you, sir. Shall I share my screen?
Yes, please. Please share your screen. We can hear you.
Is my screen visible?
Yeah.
Okay. So let me begin by thanking the SOGO organization, and special thanks to Dr. Ginil also for inviting me to give this talk and discuss regarding the evolving role of artificial intelligence in radiation oncology. So I'll skip the initial introduction part, which has already been covered in much detail, telling us what is deep learning and artificial intelligence. Deep learning, the concepts of deep learning methods in radiation oncology has taken its evolution here, with 2018 being the peak of expectations with the first FDA-approved software for auto-contouring. And right now we are in that phase of the maximum productivity, where it is slowly getting incorporated into our clinical practice as well. So the following years, or the coming years, are going to be quite exciting for radiation oncology with regard to artificial intelligence. So I'll just take you, what I'll try to do today is take you through the radiotherapy workflow and try to see where artificial intelligence can play its role in simplifying the process of this very complicated planning process for us. So initial aspect, as per any cancer treatment, is going to be patient evaluation. I'll not delve into much detail because already Dr. Vasant, Dr. Veena, and Dr. Nithokosh have already dealt in the details, where the radiology, the pathological diagnosis, the radiogenomic assays are all going to help us achieve a much more personalized and tailored evidence-based decision making. So the first step in our radiation planning is always the most important step is the simulation, which is a very important step, and any error in this step is generally going to affect the entire treatment process. So a very good immobilization or tracking method for moving tumors is a very important aspect where AI is going to play a big role. In synthetic CT scans, creating synthetic CT scans from the MRI data, especially for tumors like prostate, where it's much more better visualized on an MRI. The convolutional neural networks have been found to be much more very efficient method in creating these synthetic CT scans, and hopefully we'll reach a day where we don't need a mandatory planning CT in the future. Virtual 4D MR images are also being synthesized for real-time image guidance during the course of treatment. The most fascinating aspect of AI in radiation therapy is the target and the normal tissue segmentation, where the first step generally is the image registration, where you need to align the two different images taken at two different time points. We do have currently a reasonably good registration methods, but they are still computationally intensive and time consuming, and AI algorithms will help fasten this process, improve the accuracy, especially with regard to mitigating the effects of image artifacts, and thereby give us a very optimal registration. And more, the auto contouring is a very fascinating thing to be incorporating into our practice. Currently, we do the manual contouring, which is a very long, tedious process with high degree of inter-person variability. Atlas-based methods are available currently, but AI tools would help minimize these differences and shorten the duration of this important step in RT planning. Currently, we have a few which have been FDA approved. The Mirada's DLC Expert is approved in 2018. It is the first artificial intelligence-powered auto-contouring solution for normal organs, following which there are other commercially available ones as well. Recently, the first AI-based auto-tumor contouring solution, where you can the software contours the tumor as well for you, is available, which is going to revolutionize the contouring aspect or the auto contouring aspect in the future. The RT planning is a very complex process. Once the contouring, everything has been done, the RT planning is a very complex process, which currently in most centers are computer-based optimization, allowing only for a small margin for error to achieve that right balance between tumor control and normal tissue toxicity. It is still a very labor-intensive and time-consuming process with still some degree of trial and error process happening. So hopefully AI algorithms will refine this planning process, improve the efficiency and quality to achieve a completely automated treatment planning process. It can it can be used in a lot of the steps that we use for RT planning, which I will not go into detail. But you can see that with the evolution, we have been more complex plans can be created, and currently variant and research laboratories have created machine learning auto-generated treatment plans, which will significantly reduce the planning time from days to just few minutes. The treatment delivery part is also a very important aspect of the radiotherapy, where it is important to monitor the inter and intrafraction motion and the tumor tracking to make sure that there are no errors during the course of the treatment. Image-guided radiation therapy is a very important, where the daily the images, megavoltage or the cone beam CT images which are required, the decision making can still be done, and the delay in decision making can be overcome by AI algorithms. Adaptive replanning is a huge prospect for AI, where it is able to identify the significant anatomic variation, whether it is causing dosimetric variations, and will be able to create a new plan on a daily basis within minutes. And this is it is one of such the variant product which was approved in 2020, which is able to acquire an onboard CT image, compare it to the basic treatment plan, and deliver an entirely adapted treatment plan within a 15-minute time slot. So it really fastens the process of adaptive replanning as well. This is such a complex process happening during the process of your radiotherapy. It is also important to make sure that there is some quality control, or else our reliability in such algorithms are going to be less. So hence, this is a quality assurance is also an important step, and automating this quality assurance with the help of AI is definitely going to make it much more a simpler and less labor-intensive process. This I'll not go into detail because already Dr. Mehta has, but it is an important aspect of post-treatment assessment of tumor response, survival prediction, predicting which patients will develop toxicities. Machine learning algorithms will help us achieve a personalized radiation therapy, hopefully in the future. Clinical radiogenomic assays are going to play a huge role in deciding which patients will benefit from radiation therapy, which tumors will respond better to radiation, do they require a different dose, do each individuals require a different dose. So all these will help us in the future. To summarize, I think AI is going to have a huge role to play in all these aspects, from treatment decision-making, imaging, treatment planning, replanning, quality assurance during radiation therapy delivery, accurate radiotherapy delivery, and as well as in the follow-up. This is going to benefit the whole team, I feel, whereby we'll be able to find the right balance between patient interaction and computer interaction. Hopefully it is in the direction more time is going to be spent with the patient rather than with the computers. So to conclude, I feel the future of AI is quite bright. Its clinical application will soon be a reality in the near future, with more and more growing evidence. Over the next 5 to 10 years, hopefully it will be adopted in our practice as well. And we'll hopefully reach the ultimate goal of a personalized treatment for all our patients. These are my references which I've taken. And I need also a special thanks to my colleague from Kerala for a few of his slides. Thank you.
Thank you so much, Dr. Nair. We will have to conclude the session now. May I just say that based on your talk in radiation oncology, it appears that the main role of AI will be in reducing this whole multi-step complex process, the repetitive process that we do into a much quicker ways, and that we can save a lot of time. So I think that would be the main takeaway. Thank you so much.
Yes.
Thank you. Thank you to all speakers of this. Thank you to Dr. Ghosh and Dr. Veena. Thank you.
Thank you, Vedang and Sundar. We'll quickly move on to the next session because we have got limited time. Yuvraj, can you introduce, invite Vineet, because Dr. Vineet has to attend another meeting now.
So who will be the speaker now, Ginil?
Dr. Vineet Talwar.
Okay, fine. So welcome to the next session. I think it's my pleasure to introduce Dr. Vineet Talwar, who is a renowned medical oncologist and director in Department of Medical Oncology, Rajiv Gandhi Cancer Institute in New Delhi. And he has many publications, and we have heard him in various meetings. A very good orator, and he's also a fellow of Royal College of Physicians, FSCP, and also a teacher for Diploma at National Board who trains medical oncologists. So over to you, sir. Ginil, is he there?
Can you share your presentation?
Can you unshare? Then I'll share.
Yeah, it is already unshared. You can share.
Somebody can, yeah. No, so I'll just try. Can you see my slides?
Yeah, we can see. Go ahead.
Yeah, fine. So, and I thank the chairpersons, especially and Dr. Ginil. So I was just going to touch about the AI digital algorithms in medical oncology. It will be a very, very basal talk, and of course, we can build up on that. So as we have discussed, AI, machine learning and deep learning have made a very promising impact on healthcare. And this is it is imaging, that is improving cancer screening and diagnosis, translational oncology, clinical decision making, delivery, which I'll just give an example, and of course personalized medicine, which is the sheet anchor in medical oncology. So the deep learning neural networks have been utilized to predict protein structure, classify cells into a distinct stage of mitosis, and even predict the future lineage of progenitor cells based on the microscopy images. So this also can be used to predict the cancer cell sensitivity, which is something of an enigma as of now. You have bacterial sensitivity, you have fungal sensitivity, but to predict these would be the next vista in the algorithms in medical oncology. And to forward that, you have so many studies in which you have drug target interaction and strength prediction, to polypharmacy and side effect prediction, to cell cycle reconstruction and disease progression, transcriptomics, and cancer cell drug sensitivity prediction. So all these are there in the pipeline, and these are being applied in the artificial intelligence in medical oncology in phase 1 and phase 2 studies, and the results have yet to come. So this is just a concept, just to give an example. You have a drug like paclitaxel, which is being used routinely in paclitaxel. There is a concept reduction algorithms against the tumor to prevent drug-resistant cells from outnumbering the drug-sensitive cells. This is the basic problem in medical oncology, where you have development of drug resistance over a period of time. So the AI has been used as an adaptive therapy in 2 algorithms, in which AT1, that is the adaptive therapy 1, was to reduce the AI in translational oncology, and adaptive therapy 2 was to have a fixed AI and a translational oncology along with the drugs, that is paclitaxel. And it was found out that the one which had AT1, that is algorithm which reduced AI and translational oncology with the drugs, improved tumor control and survival. So these are very, very initial stages in which adaptive therapy is being added on to the routine chemotherapy protocols to find out whether the anti-cancer therapy administration can be augmented to get the best cell kill. other areas also in the dosimetric analysis in genitourinary cancers, in lower cancers like rectal cancer, especially in silico analysis using clinical and dosimetric data, along with the other predictive factors to produce maximum cell kill and at a good quality of life. When you talk of the immunotarium, so AI could be used to build combination therapies with targeted major histocompatibility complex, that is MHC, which is binding to the immunological drugs using the CNNs. So this is another area in medical oncology where the combination of a targeted drug
Dr. Vinit, we can't hear you. I think there is some issue. Yeah.
Am I audible?
No, there is some issue with your internet.
Am I audible now?
Audible, but your slides are not
clear.
Hello?
Yeah, you're logged out. Your slides are not visible.
Slides are not there. I'll try to share again. Just give me a second.
And your voice is also not very clear.
I'll just try to share it again. Is it okay now?
Still, we are not yet seeing. It is showing us that the process is on. Yeah, fine. Now we can see it, and your voice is not very clear. I think your internet is unstable.
Yeah.
Go ahead.
Again, I see.
Yeah,
so
your
I think
voice,
that is why
your
I
voice is
stopped my
breaking.
video. Yeah, am I audible now?
No, your voice is breaking. Intermittently audible.
Okay.
Okay, go ahead. So the time is
Now is it okay?
Yeah, okay. Tell me.
Yeah. So this is
Again, you're logged out.
Vinit, can you please correct it so that we can move to the next presentation, as we are running behind schedule? Yuvraj?
Yeah.
Can
Tell
you
me,
please
should I go to the next one so that he can come back if he is ready?
Yes.
Okay, fine. So then Dr. Dibakar is ready, right? So can I introduce him?
Yes, please.
Yeah. Okay. So Dr. Dibakar is working at one of the prestigious institute, that is Orsi Academy, Belgium. So it is the Europe's largest training center for robotic surgery, and he is a civil engineer in the beginning. Now I think it's really good to see he is pursuing his urology residency in this Ghent hospitals, and he is also expert in 3D visualization and 3D reconstruction. I think it is a combination of technology and medical. I think we can expect that he is going to do really a good talk for us regarding this artificial intelligence. So, Dr. Dibakar, so over to you.
Thank you very much for the kind introduction. So, quickly sharing my screen. Should be able to see it now. That all is fine?
Yeah, we can see the screen, but your voice is a little breaking. So,
I'll see what I can do there. If it persists, I'll switch to another Wi-Fi network, but I don't know if it's any now.
Yeah.
Okay. So if my voice drops, I'll just turn off my camera to save that solution. Okay. So introduction. Very happy to be here. Start by ORCI Academy. So basically here you see our center, and going to the next slide now. This is where we are based. So we are based in Melle, which is in the center of Belgium. And we are a center for minimal invasive surgery, and we have all types of surgical robotics that we do. So here you see our CEO, which is Alex Montry. He's a professor in urology and world renowned in the robotic urology section. So we have different types of robotic systems, including the new Hugo robot, but also CMR, Da Vinci. So we are agnostic for vending, but we are really focused on training. So our methodology is evidence-based, and it's basically considers every type of, so also endovascular, basically everything that and minimally invasive. So that's basically the introduction, the ORCI point. I will, for the sake of time, switch to the content of the presentation. So the current state in robotic surgery, as you can see here, I will give my presentation based on a patient case. And I see that my internet connection is unstable. So I'll quickly check if I can turn off the sound. So should be maybe a bit better now. So what we see here is Andrew and Andrew Ng. I took him as a patient because he's the founder of Coursera. And if you want to dive into artificial intelligence, what you need is you need his course. You need to have this type of person to instruct you from the basic what artificial intelligence is. And I propose, so for those who are not aware of artificial intelligence, that you look at what he is doing. So Andrew presents himself with some flank pain, and he gets a CT scan. And you see in the CT scan that there's a renal loss, right? So it's a classical story of somebody coming in for something, for another disease, and being found a renal tumor. So we make a 3D model out of the CT scan, you can see here. And then the question arises, what is the best therapy for him? And the best therapy for him in Europe would be a robot-assisted partial nephrectomy. So let's dive into the 3D model at first. So how do you make a 3D model? We already heard about this from previous speakers. So what we see is that we need to color in the different slices of a CT scan. So what does this mean? It means you need to go through every slice and indicate what the different types are, being parenchyma, arteries, the venous system. And this is basically the same as we saw in the previous talks of radiation oncology, that it delineates where it needs where the different organs are. If you do this manually, it takes you a lot of manual process, which will do up to 1 hour, an hour and a half, up to 2 hours. If you're experienced. If you're not experienced, it might easily take you 2 hours and a half, up to 3 hours. So you see that you really need to go through all of this to really complete the segmentation. Of course, this is where artificial intelligence comes in. If there's some lengthy process that takes a lot of time, this is really where you can make a difference. So what did we do at ORCI? We took all our 3D models, and we put these 3D models into a neural network, more specifically 3D UNet, which is a very known neural net to do. And what you have then is that we automatically generate these types of models. So and in the top, you see what we do manually. And in the bottom, you see what the system spits out. So it makes a completely automated segmentation in 3 dimensions. So where in the oncology, the slices are done 2D, where the delineation is done on the 2D slices, here it's done as a whole. And you see that the system performs fairly well, and you have an enormous reduction of 2 hours of segmenting up to 15 minutes. But then the question arises if this patient should have a partial nephrectomy. How do you want to tackle this lesion? Do you want to do this fully clamped? Do you want to do this off clamp? Just to mitigate your risk of bleeding. When you do a full clamp procedure, you have a lot of ischemic volume, which might be important when you have a patient that is that has a single solitary kidney or that already has chronic kidney disease. So there's a whole gamut to choose from, and what we focus at Ghent University and at the OLV clinic in Aalst is the super selective clamping. But the question is, how can you predict this? And this is also where AI comes in. You have an automated 3D model, but where does this help you? Well, it basically helps you in automatically presenting the perfusion. So you can predict the perfusion. So we have this 3D model in which we click the different arteries, and we can show the zones that are becoming ischemic. And it allows us, when we look at the tumor itself, from the tumor bed where we will be doing the enucleation, we see the bottom of the tumor will not be still be fed with blood, and then where the top is completely avascular. So when we then do the procedure, this is the procedure performed by Professor De Kaastekker, who is very involved in this research. You see that we mark the vessels. So we always put a safety line around the main renal artery, and then we go and look for this the second and the third artery segments. So we now find the artery which we think that will be perfusing. We clamp that vessel, that specific vessel, and we give ICG. And so the ICG is now circulating in the body. And when we check the perfusion, we see that the lower part of the kidney is still receiving oxygen-rich blood, and the top is not receiving any blood. And this is basically what our program, our intelligent program, predicts. So we can start the tumor resection now from the point which is avascular, and in that way really reduce our risk of bleeding. So here we see the start of the enucleation. So we're looking for the pseudocapsule to start to find the right plane. And once we really start the enucleation, you see that you will see very soon that at the point where the suction device is, there is still blood coming, while the upper half is completely. So here you see that it's really the blood is oozing from the lower half. So I'll quickly turn that back a bit. So you see that the lower half of the tumor bed is still bleeding as predicted, and the upper half is avascular. And if you know this up front, you can choose your angle of attack in this procedure. So that being the prediction of perfusion. We also do instrument detection. So Professor Bandari also mentioned how his group is working on the detection of kidney vessels. We believe that the detection of instruments is very important for several things. So here you see how the different instruments get their color automatically assigned. On the right half, you see when the background is blocked, how these fast-moving images can still be detected very precisely. And you might say, okay, how is this useful? Well, this is useful if you want to give vision to a computer. As Dr. Bandari said, you can help a surgeon detect certain points of view, but you can also help in the augmented reality. So here you see our 3D model overlaid, and we saw a very nice presentation of an elastic model by Professor Bandari. And what you see here is if you can detect these instruments, the augmented reality becomes even more realistic. So it becomes a reality because you can move your instruments on top of that 3D model. So this is why you need instruments, but also we also saw the detection of bladder tumors, of papillary lesions. You can also do this exact same thing with these bounding boxes in surgery. So here you see one of our training simulators, and we automatically detect where this needle driver is going. So this is another type of automated computer vision in which we detect the region of the instrument. And you might again say, why is it useful to know? Well, as a teaching institute where we learn people robotic surgery, it might be nice to know when the instruments are moving, how they are moving, and what can we derive from that concerning the level of the people who are receiving the training. Where it used to be see one, do one, teach one, we no longer believe that, and we use a methodology called proficiency-based progression. And it's really standardized how people are trained, and that's what we focus on to really improve training and to improve patient care. So we saw some neural networks, and we saw a lot of examples. So quickly recapping this in the instrument detection, basically what a neural network does, it goes from the input image to a decision. And the farther you get in the network, the more precise the details become. Just like in your brain, you see something, and it's only in the secondary visual cortex that what you see gets a meaning. And basically, this is the same thing. You see an image so this is a cardiere. You see for this instrument that it has some ridges, and then you see the nodes with these type of ridges and this type of hinges being activated so that in the end you get the right classification. What can experts learn from this? So here you see Professor Motry and Professor De Castecker, who are in Belgium very well known for their partial nephrectomies, and you can really derive a digital fingerprint from this type of procedure. If Professor Motry does a tumor resection very fast, well, both of them, they will never be able to attend the cases from each other because they are very busy in practice and they are never able to attend each other cases. But if the system automatically derives this type of information from their surgeries, Professor De Castecker can learn how to do a faster tumor resection. And you see here that Professor De Castecker, he uses a lot less instruments and his operation time is shorter. So Professor Motry can also learn some things of Professor De Castecker concerning how to use the instruments. So both can learn from each other and make sure that the robotic surgery as a whole advances into a higher field, because everyone has his own tips and tricks, and artificial intelligence and machine learning allows you to derive these tricks. What does the future hold? This is a small demo of not Orsi Academy, but this is a group that has a system in which you automatically automatically steer a robot, and here you already see an automated suction device. So you see a fully automatic suction, which helps you, and you would no longer need a bedside assistant providing constant suction when a system like this exists. So we had a discussion up front in which we talked about what does this mean for the profession of a surgeon? Will we be replaced, or what will happen? And what I basically always try to conclude my talks with is that the artificial intelligence, it does not replace the surgeon, but it affects the surgery. And I think this is really our vision at Orsi Academy, is that we should perfect the surgery, but we shouldn't be afraid to replace it. So we should systematically think about collecting the right data, making things better and improving the care, but we shouldn't too much be afraid of replacing it, because in the end, it's always a human in the loop system where the surgeon is responsible for what is happening. So this is really one of the key messages, and I think that's a nice one to conclude. Thank you very much.
Thank you, Dr. De Backer. So I think it was an excellent talk on the use of the modern techniques like 3D reconstruction. I think we will go to the next speaker. Raghu, am I supposed to?
Dr. Anish Srivastava.
Yes, okay. So let him.
Thanks, Yuvaraja, and good evening, everyone.
Yeah.
It has been a grand session going on with my mentor, philosopher, and guide, Professor Bhandari, at the helm of the affairs. So, gentlemen, it gives me great pleasure to introduce Mr. Nikhil, the consultant urological and robotic surgeon. And he is the associate medical director for the cancer services and also works as a senior clinical lecturer at the University of Hertfordshire, where he does mainly the research work. He has a lot of awards to his credit, and some of them are the Doctor of Science from the University of Hertfordshire itself, and the International Professor by the Apollo Group of Hospitals. At the end, I would say he's my personal and family friend. Now, So I present him to you for the great talk. Mr. Nikhil Vasudev, please.
Thank you very much, Professor Srivastava. I'm just going to start off, if I may, by sharing my screen. So I hope my connection is stable and you can hear me. So first of all, thank you very much for the organizing committee for the invite. My topic today, which was allocated, was the future considerations for AI. And obviously we can talk about AI and how it might make us vestigial in about 100 years. But I thought I would share with you some data of mine. And I'm really pleased to report that I've just got an AI clinical trial, which is about to start in the next 2 weeks. I just want to show what it takes to get an AI study going at the moment. So 2 of my projects at the University of Hertfordshire, one is to do with robotic haptic feedback, and the second is to do with molecular targeted surgery using gamma cameras, SPECT CTs, etc. But what we are seeing with these projects is that we are ending up with a lot of data which is making its way through. So we're trying to really stratify and make this a little bit more streamlined as to how we can collect this data. And I think this is when AI will come into interplay to allow our patients to benefit. Now, in the UK, what happened last year during COVID, and sadly the COVID pandemic is very much, although the pandemic is, whatever you rename it, COVID is here to stay. And we saw a significant decline in the number of cancer referrals that were coming across in the NHS, especially NHS England. This is data which I say as I sit as a part of the COVID-19 national response team. And with prostate cancer especially, we saw a drop in 70% last year with the number of prostate cancer patients coming through. Hence the reason why on a Saturday, we are still operating. I've done 2 prostates. We have 7 biopsies, which we are doing. So we are seeing a surge in the number of patients coming. But what happens is with the surge, it puts a lot of pressure on any healthcare system all over the world with the number of patients coming through. So I feel that AI, with all the great presentations that I've seen so far from Dr. Bandari and the pathologist, the radiation oncologist, and Pierre, and obviously Carol is a very dear friend of mine, is the pressure on the system will exist, and how can AI potentially help and propagate solving these issues? So I published this paper early on this year in which we took a bit of a spin to see where AI, COVID, and Uro-Oncology might be able to sit together. So, we found that obviously with the data making its way through from Italy, etc., with the pandemic, that patients who were on androgen deprivation treatment for prostate cancer were slightly protected from COVID, and the theory in relationship was down to the TMRP SS2, ADT mutations, etc. So large-scale data using AI with COVID will help us really find the way in these patients as to why certain patients were affected worse than COVID, why more men got COVID and died from COVID compared to women. So this is an interesting role to play. And I think, AI will certainly help fast track some of the conclusions we come with mega data capture. So this is a paper which was cited recently in a couple of talks that have been given. But what we did was we looked very closely as to not only the current applications for AI, but also what the future applications are. But there are a couple of negatives which I want to discuss too. It's not, one fix for all. AI has a lot of work that is required with proper randomized control trials to see where we can get to. So what are the limitations? So, what are the limitations of AI? So first of all, the initial limitation which comes up with is there's a lot of heterogeneity taking place in research methodology. We also have come up with the fact that meaningful comparisons between algorithms and quantitative analysis is slightly difficult to achieve, especially when you have new technology with lots of data being generated compared to clinical outcomes. That requires a degree of robustness for results in a majority of the AI algorithms being trained. And I use this word called overfitting, whereby models may have a slight bias to propagate poor data, which needs to be considered very carefully. And obviously, you might have a slight bias in the predictability with machine learning techniques, especially when there's poor representation of data taking place. But I think there are lots of strengths too, which we mustn't forget. So I think if you add data, this test I did in my systematic review, which was proper systematic review, it wasn't an narrative review, is AI certainly gives you the ability to look into large volumes of data for powerful predictive modeling. It lets you create multi-institution open access databases. So, with collaborations, this may be fast-tracked. But again, with unstructured data, which makes its way through, I think, especially with multiparametric imaging, genomic profiling, a lot of omics, which are increasing, this will come into play. So organizational ability of databases will really be maximized, not only from the potential of what the data shows, but also from the perspective of clinical applicability. So the question comes up, this is what AI may be in the next few years. So you have nanorobotics in which you're injecting particles. This is data from Germany. You're injecting chemotherapy robots into patients. Is this going to be the future? It may be, but I don't see this for sure, certainly in the NHS, happening in the next 1 to 2 years or the next 2 to 3 years. We have to be realistic, because this is science fiction, but so was robotic surgery 20 years ago. Things may propagate, but let's look at the immediate issues which are faced and what can we do. So, Dr. Bhandari made a very important point about the learning curve and how AI may help resolve this. So this is data from our fellowship program, which Ashwin Tamankar, when he was my fellow 2 years ago, looked at, in which we were able to calculate, when does a fellow really get better? How is this achieved? How many cases are required? And on complex data analysis, we thought that 80 patients or more a year, or 80 is the learning curve, but you need to do about 300 to get better compared to, in comparison and in line with Dr. Tewari's paper. But whether AI will potentiate this training and learning curve, we do not know. But I certainly think so with the techniques which are being presented with AI and training. I collaborate with Carol a lot, like I mentioned, and he talks about partial nephrectomies. We're doing some cystectomy work too. So I feel this learning curve will improve so that you don't require to train on 300, 400, 500 patients to get better. You might want to train on 10, 15 patients to get better. So that has a strong role to play. And in my center, we do a lot of nerve-sparing prostatectomy. We do neurosafe prostatectomy. So this is fresh data from my fellow John Hayes, who's just collected this in 500 patients. But what we require when we do a neurosafe procedure, an oncologist to be present in theater who does the analysis live. So what we've looked at is the application of how AI can help solve this problem, in which whether we can have a better predictability of neurovascular bundle invasion, T3A disease on MRIs, etc. And again, can this improve the learning curve of newer techniques that you're trying to adopt in a fast-track, safe manner? Because what we found is that with our nerve-sparing program on 600 patients, our continence, our erectile function recovery, and our positive surgical margin rate is significantly improved. So we collaborated with a few centers in the NHS, in which we have now looked at something called the PAIR study, which is prostate AI research. This is a multi-center collaboration taking place, targeting about 2,100 patients, in which we're looking at MRI predictability to spot cancer, both on a 1.5T and a 3T. But I've been very fortunate to be awarded a grant nationally on something called the PAIR-2 trial at my center, in which we are looking specifically at the robotic prostatectomy population in a slightly retrospective manner, in which we look to evaluate and see whether we can predict neurovascular bundle invasion and T3A disease. So this is HRA approval that I got across on the 21st of July with some funding. And the project starts off in 2 weeks, in which we're looking at software capture to collaborate this with robotic prostatectomy outcomes on table. So this is real life, real world data, and I'll hope to present this at the AUA next year when the data is mature. So what we are looking at right now is to see whether with the use of an MRI and AI, we can have better lesion location, some degree of risk prediction, and obviously automated reporting. And automated reporting is not to replace uroradiologists, it's to help them out. And my uroradiologists, 5 of them in my center, are very receptive, because all our patients who are referred in with an elevated PSA have an MRI before they come and see us in the clinic. That's what we tend to do in the UK now. So that's standard of care in a lot of centers worldwide now. And what we have done is translated that to look and see whether we can evaluate the margins, extracapsular invasion, neurovascular bundle involvement, SV involvement in the context of surgical translation. So Again, this is early data. This is how the software runs. It takes about 20 to 30 minutes per patient per scan. It's installed onto the radiologist's computer. But right now we're looking at 500 patients who've had 1.5 and 3T MRIs to look and see whether we can look at neurovascular bundle invasion with whole mount and robotic prostatectomy specimens. So this is how we are looking at the whole mount MRI with whole mount robotic prostatectomy specimen. So exciting stuff ahead, and I'll obviously report back when the trial is up and running and what the pilot data shows. So the question is, AI has been around for many years. You know, airline pilots, the aircraft sector, engineering sector has been using for many years. But why is it important right now, especially with the COVID-19 pandemic? Because the incidence of tumors will increase, the population's increasing, the risk of overdiagnosis and overtreatment, which has been propagated, especially in patients who have high risk for metastatic disease, you want to bring them in earlier into your fold to treat them. Because what we see right now is that in England, 56% of patients have advanced or high risk or metastatic disease when they come through. Overdiagnosis or overtreatment of low-grade disease remains a risk, but we want to better ourselves with technology. So I feel that AI will definitely work towards faster and lower cost diagnosis to be prevalent, but increased sensitivity to take place, better specificity to take place, and better surgical options. But the important but is, what is the validation protocol that we need to follow? So this is what we are doing right now, which has been approved with our research body, the NIHR, on our trial, in which we have looked to see how AI systems might improve specificity. I think sensitivity is slightly reduced because they tend to overcall on the data sets, on the overcall of predictability, but we want to develop systems which have better sensitivity, negative predictive value, and certainly specificity is also improved. Whether this will change decision planning, we do not know, because you probably put through a lot of patients through a lot of newer technologies and scans, but there is a prediction that this will improve better surgical outcomes, and also, you know, it may not require as much expertise for every radiologist to spend hours at end looking to evaluate at every MRI taking place. So some catalyzing of time for them. And also the important thing is we must monitor the impact over time, especially as software updates, etc., make their way through. With external validation and prospective valuation, this is what we tend to follow with our protocols, in which deep learning modules obviously have a lot of parameters with imprint data. There's overtraining, which could take place, but we can't really generalize this from the point of view. But we need to develop models and measured parameters on evaluation of data and not external validation. We want an internal validation process, and we really need to see how unseen data works in real life practice, because this sounds like science fiction, but we need better quality of evidence to take place. And that comes down to the fact that there are very few publications only, when we did our systematic review, which meet the claim requirements, especially and particularly with external validation. So my conclusion in my systematic review was, we need new databases to be realistic in performance to fix this validation gap. So, you know, I think prospective randomized control trials are on the order of the day to really figure out if AI is going to help us. And this is what we have proposed, is the development of a standard of care pathway versus an AI pathway, so that we can look to see whether any intervention in any step, be it with data capture, reporting, review, is all validated together. Because what we don't want to do is, when we consent and randomize patients in the pair 1 trial, which will start soon, is that there is no discrepancy taking place, because we want to make sure that AI doesn't miss significant cancer. So the other role, which I think is very useful right now, which we're using, is also to predict neoadjuvant chemotherapy response. I think patients with bladder cancer have been ignored for a while, so we need some better data to show how we can predict how AI may be in a position to tell us if patients are responding mid-cycle to neoadjuvant chemotherapy versus those who are not. And I think this has a strong role to play, because survival depends on neoadjuvant chemotherapy response. Image capturing software with blue light cystoscopy, we are working with Karl Stotz at my center, and certainly Arnold Schnetzel in Germany talks a lot. He's just published a fantastic paper on image guidance as to how the image itself with AI can predict both CIS and muscle-invasive bladder cancer. So this may have a role to play, which we may not biopsy all patients who have a Barndo muscle-invasive bladder tumor. And certainly with renal imaging, the important thing to be aware of is the multiple imaging studies coming through, in which when you look at radiological intervention, you want to evaluate the sensitivity and validation of projects. So if you look at this particular table, which I've submitted for you, the sensitivity varies from about 70% to 84%, but the real important aspect is the specificity is very high, especially in patients who had partial nephrectomies or having follow-ups, which seems to be a bit of a challenge, as to, is this a tumor, is this not a tumor, what is going on? So I think AI will have a strong role to play in this cohort of patients. My topic was, what is the future application of AI? What are the future prospects? So I've just summed this up. So I think fuse analysis of a lot of data streams is under research right now, but I think it holds a very powerful prognostication, early prediction of disease, especially in neurological cancers, but it stems to the steps of truly personalized healthcare. So you want to have AI which will predict how a patient will behave, so it's personalized healthcare. Surgical skill data transfer, like Professor Bhandari mentioned, you want the learning curves to improve, but also on the last talking pair is whether you can translate this into other parts of the world, whether you can have predictability of AI software. I percepted robotic prostatectomy in Hong Kong yesterday morning, and it was all down to not so much to do with AI, but the tech in which you can sit in the UK and you can preceptor an operation thousands of miles away. So I think that will improve with AI. Again, improvements in machine learning and automated radiological and histopathological interpretations, as highlighted by some of the leading speakers in the talks earlier on, in which you want to ensure that there's a big throughput of patients, but also there's a safe throughput. And I think surgical research that is required right now is largely the need for prospective RCTs to ensure the benefits of urologic oncology are confirmed in a proper scientific rigor, which is yet to happen. So just to conclude, if I may, I think computer scientists, pathologists, radiologists, surgeons, policymakers will now need to collaborate a little bit better and appreciate that human expertise goes to a point. But when the AI systems are being developed, we need to train and develop them to what we require. I think we don't have to be job insecure. We are fine for the moment. But human qualities such as compassion, intuition, reasoning, and experience will never be replaced by AI. And I think Professor Prokar Dasgupta gave an interview in the newspaper a couple of months ago in which he was asked, will robots replace surgeons? And he said, absolutely not. Because AI augments and in the new future may collaborate to deliver an immensely superior healthcare system, but not only in urological malignancies, but I think worldwide too. So thank you very much for the opportunity. And I'm very, very grateful to Dr. Chinnal, Dr. Raghunath, and the organizing panel, Dr. Srivastava, Professor Srivastava, of course, and Dr. Yuvraja for chairing this session. Thank you very much.
Yeah, thank you, Nikhil, for the great talk. Dr. Yuvraja, do we have time for some question answers? Or
yes, we'll be skipping the panel discussion, so we have time.
Okay. So I think I'll just comment about the talk by Dr. Debaka, right? Because I think we are going to give the talk to Dr. Talwar. Ginil?
Dr. Talwar told that he has almost finished the talk.
Okay.
So
fine,
we'll skip that.
Yeah. So when whatever we could listen from him, so it was a very good topic actually, because the role of artificial intelligence in medical oncology is a very exciting thing, especially in the era of targeted therapy and immunotherapy. Anyhow, unfortunately we could not hear it properly or to the complete. But the talk by Dr. Debakar, it shows very important light on use of 3D imaging. I think that is one of the things which we practice now in almost all cases, and which gives the importance of preserving the parenchyma, which is functioning. So that is the most important thing when we do partial nephrectomy, apart from oncological clearance. I think with this, these are the few things which we could notice it, and it was an excellent talk. So over to you, Dr. Srivastava, to comment on Dr. Nikhil Vasudev's talk.
Yeah, I think Nikhil gave us a big canvas actually about the entire uro-oncology, and we have seen the role of the radiologist, the role of the pathologist, the molecular biologist, everyone across the canvas. But what he has shown us is the actual clinical, its impact on the clinical practice. And if I could maybe understand what, there are certain things which are in the pipeline ahead of others. So I think the major impact would be on the partial nephrectomies. And I think the data, enough data has been presented. Then I think second thing is that the neurosafe kind of radical robotic prostatectomy. That is where again the AI and machine learning is going to help. And probably the third area could be in the cystectomies, where nobody has talked about, and about the diversions, and how to make them safer, the intracorporeal diversions, because most of us we're not doing the intracorporeal diversions. So we need to have some future projections by these giants in this field. And I think that is what is there, which is glaring at us. And then, of course, there are a lot of things, right from screening to diagnosis and, investigations in the various cancers, which will come later. So I think those are my brief comments.
Thank you, sir. Ginil, you have to unmute. Ginil, you unmute.
Thank you, Viraja, Dr. Anish, for excellent moderation. Nikhil, there was a question by Murugesh Manohar, and I just I skipped earlier. This is an interesting point he was raising. Why we are calling artificial intelligence? It feels like it is a fake intelligence. Why shouldn't we make the term augmented intelligence or something similar?
I think you can name it whatever you want, Dr. Janil. I think all the terms are basically just synonyms as to what we're trying to achieve, because if it's actually augmented, but it's beyond the human brain to predict this level of data. What I learned with especially our haptic feedback project, because I work with 7 engineers, and I promise you, we as doctors, our brains work slightly differently than our engineers' brains work, and I'm sure Peter has the left and the right hemisphere, which meets in the middle somewhere. But the amount of data that is generated, I think sometimes can distract what the key message is. And I think AI puts into perspective as to what we're trying to achieve, both in the short and the long-term goal. That's the way I've looked at it. And once you stratify that message, and the data is made to predict what you want to see, not manipulate, but it gives you a very accurate picture. Otherwise, you're just lost with such mega data making its way through. Like especially during COVID, when we had controversies as to why more men were getting COVID, why patients who were on androgen deprivation treatment were more protected. These questions will take many years to answer, because this will be multi-center data which will come from all parts of the world. So, your question is, you can name it what you want, but I think it's going to help us in the long term.
Sure. In the light note, we'll proceed to the next session. If there is no questions to other faculty because of lack of time, we haven't asked any questions or discussed. If there is no questions, we will go to the final. If any questions, we'll discuss now. Otherwise, we'll go to the final part of the program. That is comments or closing remarks by Mahendra Bhandari sir. He is the person who is doing a lot of research, and his words of wisdom really have.
Thank you, Ginil. At the outset, I compliment SOGO and you for putting up such a hard work. I wish more people could have been benefited. You brought galaxy of speakers, and I enjoyed each one of talk, covered all the areas which are related to oncology. I'll talk of something I was looking for commonality in the speakers, whether they were pathologists or radiotherapists or surgeons, or Nikhil was talking more as a statistician. And so the commonality was, look, it's very simple. AI doesn't have to prove its credentials. If algorithms work in my Tesla 100% better than human beings, they have to work in surgery and oncology. Why they don't work? Everybody pointed out that we don't have that quality data. And it is not that you are not preserving data, but we are not in the culture of, I was looking at the papers on intraoperative data collection. And mostly it is the blood loss, console time, operating time, very few data, very few people even capture the physiological data. Now, I would just show you 2 slides with your permission. That first thing we encountered was the lack of quality data. And what we did was to solve that problem, because moment you talk of the data, there is a red herring, and everybody thinks that we are going to steal the data or something like that. So what we created, democratization of data process, and we invested in creating ReadyMind Ground Truth Factory. ReadyMind are my technical partners. And this is an academic platform of collaboration, wherein this is already in function. It is only for CT scans and videos so far. And what you have is the Center A, Center B, Center C in 3 different countries. It is highly secured, multi-regulatory compliant, GDPR, Indian. And what it happens is ease of uploading the data. And the key point is this inner thing is where the models are built. It's a single platform which will store the data. Whole data pipeline is built on that. Models are treated and validated on that. Most important thing is that you control your assets. It's like blockchain. No administrator, if you don't want to give your data for data making, you don't have to. Next thing is, if there is an insistence that data should stay in your country, the models could be built in your country by your people. So what we are very happy with this is that we are working on transplant nephrectomy data. Second point, the point which was made was a very interesting point. I think about a year ago, I was invited to write an editorial for Indian Journal of Urology, and I toyed with this discussion on whether it should be artificial intelligence or human intelligence or augmented. And I chose to use the word augmented intelligence. The very reason is that AlphaGo might have won the game, but there were 100 computers and 100 people behind that game. So similarly, whatever is being created is human intelligence augmented. And same thing what we see in robotic surgery. Here you see in labeling how it batters the human mind that has happened in radiology. Here is the labeling of renal vein. One of the annotators labeled it wrong. He missed the renal artery, but the model picked up. So computers better the human thing, and artificial car, the autonomous cars have already answered that we are not going to level 5 where the robots or the automation would work. It would be always assisting the surgeon to improve. It is complementary, it is not competitive. So what is the bottom line? Bottom line is that it is a huge money. 40.8% CAGR is expected by 24 on artificial intelligence algorithms. This is the latest authorization of Page software on very recently on September 23rd, FDA approved it. The key point I would like to say is democratization of process. It should, you don't have to waste 50 years to be an experienced surgeon. That is the objective. Boost non-specialist pathologist diagnostic accuracy to the same level as everybody need not be trained by Professor Epstein. That is the objective. Similarly, we are wanting to democratize the process. So there is, and precision oncology has been already talked enough, but only to recap, target molecular driver alteration, pick up DNA methylation, reducing the cost is one of the major objectives. drug discovery has very big hope, but nothing much has happened in this field. Because drug discovery, why? Because drug companies, pharmaceuticals spend on 10,000 molecules to make one molecule to the market. Why can't it be all simulated and some things are going on? And then predicting patient response, we have already talked about. So I think in nutshell, this symposium was very valuable in trying to put forth everything together. So I wouldn't say it is hype. I would say that there is a potential, and reality depends again in the ball is in the court of urologists to not run away from that. I wish 1,500 people should have participated in this, but it clearly shows that 20 people are dedicated, and we don't need that number to begin a movement. And I would say, again, congratulate SOGO management and all those who present, including Jinil, who was generous enough to invite me to participate. I thoroughly enjoyed and put it back. And if there are questions, if there is no panel discussion, we will be very happy to take those questions. Back to you, Jinil.
Sir, this 14 is the faculty list, sir. Actually, it is web streamed across, and there must be good viewership across the world.
Yeah. No, I'm just trying to say that this is not yours. I have done several webinars, but because there is a apprehension, all of us feel that this is the prerogative of PhDs and technicians, but they are helpless without the help of clinicians. Because data is provided, the insights are to be interpreted by clinicians. They can't do anything about that. So it wasn't slur. I was.
Yeah. Can I ask one question?
Yeah. Yes,
hi. Good evening, sir. Jagdish Kulkarni here.
Yes, sir. I see you. You can't change your faces by putting a headphone.
Thank you, sir. Thank you. It's great. Now, one of the questions which are bugging us and constantly being inquired by the progeny, what are the chances of we developing and can we do something on this? I think, and this will be definitely answered by artificial intelligence so that we can look at that. And I'm sure this is an area which needs to be pumped into a lot of energy as well as, money for this kind of thing. Because people are asking these questions. Younger generation, what are my chances of developing prostate cancer? Because my father has a prostate cancer, my mother has a breast cancer, and well, this is the area where we have no answer.
I think Nikhil will again ask question my specificity, and sometime we have to have a discussion on black box, because here we are in a totally different paradigm. I have about 300 papers, but most of the papers are not more than 27,000 cases or 22,000 cases. Here we are talking of millions of data points. Now, imagine if you apply the same statistical tool for millions of data points, it would be cause and effect relationship cannot be established, So what I am trying to say is to answer the question of that whether he'll develop a cancer or not depends upon whether you are able to assemble a high quality, high veracity database, which is close to 1 probability. Means zero chance, 99%. And we will be able to predict. We will be even able to narrow the characteristics by telling that these are 5 regions which are the priority variables which are the cause. But we cannot specifically have like logistic step regression that which is the cause. So I think it is possible. Everything points back to the quality of data you are using. Models will perform. Algorithms are the same. They are the same UUNet and other standard networks which we feed the data. But the whole problem lies in creating a quality data. 80% of effort, I have been working very closely with NGS, 80% of effort, I say, is in the data preparation and cleaning. 10% is in what is the collaborative platform or interactive platform you have. Only 10% is the technology of building models. I think people will challenge it, or that's what I feel while working in this field.
Thank you.
So one more question. Earlier in data analysis, we were actually trying to avoid the confounding factors. When we are increasing the data points, are you actually putting all the confounding factors together and ask the machine to discard whatever is important?
The way it works, Ginil, is that number one, first you have to forget, because you are a urologist of long standing and you have fixed points that these are the causes of this disease. So when you are collecting the data, you try to take as much relevant data as possible, because we are not looking to prove with a high level of evidence of already what is known. We are trying to look for hidden insights in the data. And that's why you have to include as much as possible. Once you have hidden insights, I also know that in that MIMIC database, we had 1,500 variables. Now, there is no way any predictive model could be deployed in clinical setting with 1,500 data points. But there are ways when you can really prioritize the characterization and pick up few data points which would be easily available in the clinic to give you a prediction.
Okay. Any other points? Otherwise, we will wind up. Yeah, Nikhil, please.
Dr. Nikhil, please unmute.
Yeah, Nikhil, you're.
Sorry. Just coming to the question with Dr. Kulkarni asked Dr. Bhandari. I think, lots of patients do ask, what is my risk of getting a cancer in the future, etc. And I think, Dr. Bhandari's point is valid, because I think traditionally we are so tumor specific driven. So for example, in the UK, we have something called the Galleria blood test trial, which is starting off, in which it's a blood test to look for 50 tumors, but it's essentially enhanced BRCA1, BRCA2 mutation analysis, etc., which is taking place. The question will come up when we do have data from these genomic studies making their way through. I think that's when AI will really come in to clear out the confounding factors for specificity on expression for specific tumors. So I think personalized medicine, like Dr. Bhandari, Professor Bhandari said, will be here to stay. But what that initial data capture will show, we do not know, because we're looking for so many mutations through so many gene sequences. I think it's just going to make things a little bit muddy. But I'm sure these companies that are investing millions into the tech have an answer, which we don't know yet.
Thank you, Nikhil. My special thanks to Gagan and panelists for not helping us by skipping their session, because of which only we could wind up the session on time. Sir, Mahendra Bhandari, sir, you are about to tell something?
No, nothing,
okay.
Nothing.
So with this, we'll wind up our session. Then I invite Dr. Raghunath, our Dynamic Secretary, to give the vote of thanks. And
before Dr. Raghunath comes, I'd like to thank Peter, who had a wonderful presentation, and we had doing very high quality work. And thank Alex Motry for permitting Peter, because Peter is in very much demand, and I had to get him on a Sunday to say that we are using Peter for this. Thank you, Peter, for this.
From my part, Professor Motry also really supports your mission, and so he sends his regards, but I will definitely send his regards back on Monday. So thank you very much.
Yeah, thank you. With this, we have come to the end of this session, scientific session. So very good evening. It was really an excellent meeting. Whatever we have discussed and we have learned may not be applicable today, but definitely in the future, we are going to apply this, and definitely it is going to transform the way we are going to treat, and immensely it is going to benefit the patients. So that is the intent of this meeting. I thank Dr. Ginil Kumar and all the office bearers of SOGO, particularly Dr. Jagdish Kulkarni sir and Dr. Raval, for guiding us in conducting this program. And I also thank all the other office bearers of SOGO for putting up such an excellent program. I thank all the international speakers, particularly Dr. Vasdev and Dr. Bhandari sir and Dr. Peter and Mr. Saurabh, and all the national speakers, chairpersons, experts, and particularly I thank Gagan for accepting our invitation and calling off in the last moment. Thank you, Dr. Gagan. I also thank Ferring for their unconditional support in conducting this program, and special thanks to Professor Bandari sir for excellent closing remarks. So with this, we are winding up this session. Thank you, one and all. Thank you. Good night. Good night.
Dr. Raghunath, would you favor me with your mobile numbers? I have a personal reason to call you immediately after.
Sure, sir. Sure, sir.
Just put it on WhatsApp. I can.
Sure, sir.
Thank you very much for inviting us. Thank you so much.
Good night.